You guys hear me okay? Okay, awesome. For those of you who I haven't met, my name is Courtney. I'm one of the ID pharmacists here at Ruby Hospital. Today, I'm going to be talking about intra-abdominal infections. And next slide. In particular, we're going to be reviewing durations of therapy for intra-abdominal infections, which can sometimes be a hot or controversial topic. Next slide. So initially, we had these 2010 treatment guidelines for intra-abdominal infections. Can you guys hear me? I think someone put in the chat you can't hear.
Can you speak up a little louder?
Yeah, can you hear me okay now?
That's better, yes.
Okay, I'll try to be louder. So initially we had these 2010 treatment guidelines for intra-abdominal infections that were published by both the Surgical Infection Society and the IDSA in 2010. Main takeaways here regarding duration of therapy is that source control is key to management and intra-abdominal infections in the majority of cases. And they did recommend initially that the duration of antibiotics after source control to be 7 to 14 days. And next slide. So source control was defined as draining infected fluid collection, debridement of necrotic tissue, and restoring normal GI anatomy and function, which is the ultimate goal in intra-abdominal infections. And failure to achieve source control was one of the strongest predictors of poor outcomes, including mortality and complicated intra-abdominal infections. Next slide. So after these 2010 guidelines were published, we did have this key landmark trial come out in 2015 called the Stop It trial, which I'm sure most of you are familiar with. It was a multi-center randomized controlled trial that included adults with complicated intra-abdominal infections that did achieve source control. And it compared patients that got 4 days of antibiotic therapy from source control compared to longer durations of therapy, which was a maximum of 10 days of therapy after source control. So it did include 518 patients evenly distributed in each group. And the primary outcome looked at a composite of surgical site infections, recurrent intra-abdominal infections, or death within 30 days after source control. And ultimately, it was found that the short course was no different between the control group with a longer duration of therapy after source control was achieved. And the median antibiotic duration in the short course was 4 days compared to the longer course was 8 days. And ultimately, in conclusion, the study found that in patients with intra-abdominal infections with adequate source control, 4 days of antibiotic therapy had similar outcomes compared to a longer course. And these findings were really consistent across all subgroups, including those with sepsis and those with fungal isolates, and did not show any benefit for longer duration of therapy, even in higher risk patients as well. Next slide. After this, in 2018, the DuraPop trial came out that assessed critically ill patients with post-op intra-abdominal infections that had adequate source control. And it did show that 8 days of antibiotic therapy was as effective as 15 days. So in our more critically ill patients, we tend to treat them for a longer duration of therapy because they might have a delayed response to clinical resolution than compared to our more stable patients. It did show in this trial that there was no difference in mortality, no difference in emergence of multi-drug resistant bacteria or reoperation rates. Of note, the short course did have a slightly higher rate of subsequent drainages, but this did not translate into worse clinical outcomes. So even if they have a shorter course of therapy or a longer course of therapy, we still could have had drainage despite the duration of antibiotic therapy. And next slide. Most recently, the Surgical Infection Society updated their guidelines on the management of intra-abdominal infections, and I'll just touch on durations of therapy for the sake of this presentation. There were some other updates regarding empiric antibiotic therapy, but I won't get into that for the sake of time today. Next slide. So they really drew on the data that was published in between the 2010 and then the 2024 guidelines updated. So their recommendations were that for most patients with intra-abdominal infections that had achieved source control, they recommend 4 days of antibiotic therapy after source control was achieved. This included patients with low and high risk post-percutaneous drainage procedures, high-risk patients with sepsis, and even higher-risk patients with comorbidities, including diabetes, obesity, or a higher illness severity. And they measured that with the Apache 2 score. And then they recommended for more critically ill patients, for patients to have a duration of therapy of 8 days after source control was achieved. And next slide. They did address the duration of antimicrobial therapy for patients without source control, with the caveat that there is very limited data and including clinical data with these patients to make a strong recommendation whenever patients don't have source control. But their recommendation was to limit therapy to 5 to 7 days in patients with an established intra-abdominal infection without definitive source control, and to use more clinical improvements, so things like resolution of their fever, leukocytosis, and return of GI function to guide earlier discontinuation of antibiotics. And really, these patients should be reassessed every week or so, and if they're not responding to antimicrobial therapy alone, we should be reassessing them for possible source control intervention. And I know in real life, we're not always able to get source control with all of these patients, so we kind of have to treat them on a case-by-case basis. Next slide. There are a lot of limitations to antimicrobial only management. As I said before, source control is the main thing that we try to achieve for intra-abdominal infections to have the best outcome. Whenever we can't achieve source control and we're limited to antimicrobial only management, this has shown a higher risk of persistent infection and treatment failure rates. Success rates vary based on the type of intra-abdominal infection, but up to 60% of patients that have small abscesses might resolve with antibiotic alone, but half will eventually require surgical intervention due to recurrence or progression. So sometimes there's only so much antimicrobials can do. And then, as we would expect, there was an increased antimicrobial resistance with prolonged therapy of antibiotics as well.
You have a question in the chat. It was, what was their definitions of source control and any recommendations for reimagining to guide therapy?
So I can go back to a previous slide. I only have like a couple more slides, so I can address that after I'm done in the next few minutes. You can go to the next slide. So when source control is not able to be achieved, sometimes we default to longer durations of antimicrobial therapy and intra-abdominal infections. But as we know, longer durations of therapy aren't benign, even with oral or IV antibiotic therapy. So I just wanted to draw on this retrospective analysis that looked at complicated intra-abdominal cases that did require surgical or percutaneous intervention. Their goal was to determine if longer antibiotic therapy had an increased risk of extra-abdominal infections, or EAI, as I've abbreviated on the slide, and mortality. So it did include a lot of cases, around 2,500 cases over a period of 14 years. It did show that there was in longer antibiotic durations in extra-abdominal infections versus non-extra-abdominal cases, was 14 days versus 10 days. There was a higher Apache 2 score in patients that had extra-abdominal and subsequent extra-abdominal infections, and there was a higher overall in-hospital mortality in patients that did have extra-abdominal infections. They did match these patients that had extra-abdominal infections versus no extra-abdominal infections, and it did show that with the development of extra-abdominal infections, there was a longer duration of therapy of antibiotics in these patients. So, and there was also a higher rate of mortality as well. So with longer durations of antimicrobials, it's not unharmful, and we should be continuing to assess the patient for interventions of source control whenever we can. Next slide. So in summary, we should, if we get source control on these patients, we should be trying to limit antibiotic therapy to 4 days. And if source control is not achieved, we should be basing duration on clinical response. The guideline recommendation is 5 to 7 days, but really we should be reassessing the patient periodically to see if we can get source control or not. If we don't have clinical improvement, reassessing the patient, if we can get that surgical intervention or percutaneous intervention. And then prolonged antibiotic courses ultimately have been linked to worse outcomes, including secondary infections and mortality. And Jacob, I think your question was, what was the definition of source control? If you go back to slide, I forget which slide it is. It might be like slide 3. I do have a definition on source control there. It's slide 4, sorry. Yeah, so draining the infected fluid collections, debriding necrotic tissue, and restoring normal GI anatomy and function. And that did come straight from the Surgical Infection Society guidelines. So that's the ultimate goal. And then I think your other part of the question was re-imaging, and they didn't address re-imaging. They just generally stated to reassess the patient, which sometimes would include re-imaging to see if we're treating a fluid collection, to see if it's getting bigger. In the case of if the fluid collection's increasing, I would say maybe we can reassess to see if the patient can have a drainage procedure at that point. But as we all know, not all of our patients can undergo surgical interventions or procedures like that, whether that means it doesn't meet their goals of care or they're not able to undergo a surgical procedure. So sometimes we're left to treating them with antimicrobials alone, and I think the best case is just reassessing them with imaging or lab values, things like that.